Alright, let's go. So I'm gonna aim to finish 9 cases for my medical exams. So I have about 80 days before sitting them, so let's grind it out. Thanks for being patient, everyone. I was just answering a ton of COVID myths about it affecting pregnancy, it causing cytokine storms, blood clots. If you have any questions about COVID, feel free to put it in the comment section and I'll answer that for you. But let's get into it. On. Thought the sound was on. Ah, that makes sense. Stream setup with audio. Right. Yeah, I've turned on the sound. Thanks, guys. I thought the sound was already on. I was doing a lot of talking. We're just talking about cytochrome P450 inhibitors and inducers. So, inhibitors include cimetidine, chloramphenicol, fluoxetine, ketoconazole, isoniazid, sodium valproate, ciprofloxacin. And your inducers include rifampicin, phenytoin, grisevalvin, carbamazepine, phenobarbital. So those are your inhibitors and activators of your cytochrome P450 system. And the context here is that warfarin is metabolized via the cytochrome P450 pathway, so those medications can alter warfarin levels. The other side effects of warfarin was that obviously there's the bleeding risk as it's an anticoagulant, but it also increases your risk of skin necrosis and formation of microthrombi, especially in the injection site. You can see that sometimes with Clexane injections in the abdomen. Now, heparin's side effects are slightly different. Heparin increases your bleeding risk as well, but heparin can also cause hypoaldosteronism. It can suppress the secretion of aldosterone, and as a result, you can end up with hyperkalemia because potassium is not secreted into the tubules through the action of aldosterone. Heparin can also cause heparin-induced thrombocytopenia. It's a transient thrombocytopenia. It usually occurs a couple of days after heparin use, and it's associated with heparin activating platelets. So heparin will bind to platelet factor 4. Heparin binding to platelet factor 4 will cause IgG and IgM antibodies to bind to and activate your platelets further, and you'll get depletion of platelets. At the same time, you can get damage to the endothelium, and that can set off heparin-induced thrombocytopenia. Now, how do we reverse our anticoagulants? Warfarin, you simply give them vitamin K. You can give them Prothrombinex, which is a mixture of your clotting factors. Platelets? No, there's no platelets in Prothrombinex. It's just factors and protein CNS. And that's interesting because protein CNS inhibit thrombus formation. And Prothrombinex. Yeah, I guess you have to give them whatever vitamin K inhibits. So Prothrombinex. Vitamin K in the early stages inhibits protein CNS, and that's why it's prothrombotic in the first couple of days. You need heparin bridging therapy. Pressure in plasma has a rapid onset. You monitor the INR. Unfractured heparin, you give them protamine sulfate. Protamine for heparin. Warfarin is vitamin K and Prothrombinex. Your DOAX, your dabigatran is reversed using Praxbind. What's the actual name for dabigatran's inhibitor? Dabigatran. Idarucizumab. That's what it is. Idarucizumab. Idarucizumab. What a name. That's what Praxbind is. Let me just write that here. Protamine is for heparin reversal, but if you want to reverse dabigatran, I believe the other two factors don't have inhibitors, and that's for apixaban or rivaroxaban. Yeah, you just give them your Prothrombinex, you give them factors. to reverse it. Put on Webster Pax dabigatran, reversed using Sizumab. Hopefully you can all hear the rain outside. It's actually an amazing time to be doing work. Everyone's sleeping, it's midnight, therapeutic, and we on the work. MI, okay, we've gone through the MI case. How do you treat an MI? So you give them nitroglycerin because it's a vasodilator, and that's going to decrease myocardial oxygen demand as well as it lowers preload. That makes sense, right? If you vasodilate the venous system, you can lower preload, and that decreases end diastolic volume of the heart, and that's going to decrease the stretch on cardiac fibers, the amount of ATP and oxygen that they need. So it's going to decrease myocardial oxygen demand. It's going to cause, now specifically, nitroglycerin. What kind of vasodilator? What kind of vasodilator? Yep, okay. It's arterial, I believe. Yeah, that's what I want to know. It's a venous, it's a venodilator. I remember isosorbid dinitrate. Venous dilation. It's a venodilator, interesting. Right, because your hydralazine is an arterial dilator. Makes sense. Maybe I'll just write that down. That your GTN is a venodilator, and that's going to decrease preload. And what is preload if not end diastolic volume? And that's going to decrease cardiac stretch. And then it's metabolic demands because the heart's not being stretched and activated as much. Makes so much sense. Decrease activation. Now, what about morphine? Well, morphine also decreases. Morphine decreases your. It causes venodilation as well, and it's a pain relief agent. So we give morphine for heart attacks as well. Yeah, interesting. And dosage 2 to 4 milligrams IV every 5 minutes. 2 to 4 milligrams every 5 minutes. Morphine, more than a couple of milligrams. Patient will die. Coronary, yes, I do think it is also a coronary vasodilator. Venous and coronary, yeah, thank you. Coronary and venous vasodilator. Morphine, 2 to 4 milligrams IV every 5 minutes. Okay, beta blockers. Okay, tenolol, metoprolol over 5 minutes to reduce. Yeah, I guess in the initial stage of myocardial infarct, you get decrease of the sodium potassium ATPase pumps, and that causes electrolyte derangements within cardiac tissue, which can predispose to arrhythmias in the acute setting. So beta blockers would be used primarily to reduce arrhythmias. Okay. Used in STEMI, so yeah, makes sense. Beta blockers, and you give them DAPT, beta blocker and ADAPT, dual antiplatelet therapy. So clopidogrel is an ADP antagonist, so it prevents ADP, which activates platelet binding, and platelet binding is critical to the early stage formation of the platelet plug before the coagulation cascade and the thrombus further consolidates. So that's clopidogrel, and you have aspirin, which is a COX, irreversibly acetylizes COX. It's non-selective and antiplatelet through its actions on COX-1. And you also give them anticoagulants. usually pretty much all patients also put on heparin to prevent formation of the thrombus as well. And you put them for PCI. PCI can involve balloon angioplasty to dilate the vessel and stenting as well. Thrombolysis is not usually done in a tertiary hospital. In CABG, if the patient is stable and they still have unstable angina, for example. NSAIDs, irreversibly stabilizes COX. We've gone through that. Side effects, bleeding, GI mucosa, peptic ulcers, can cause hepatic renal disease. Yes, because we need prostaglandins for renal artery vasodilation. So by inhibiting prostaglandins, your cyclooxygenase, when it decreases due to the action of NSAIDs, you will get vasoconstriction of the afferent arteriole, decreasing GFR, causing acute kidney injury. Clopidogrel is an ADP antagonist, as we mentioned, and alteplase is a TPA, tissue plasminogen activator, which activates plasminogen, which will form plasmin, which breaks down fibrin clots. Yep. What drug should be avoided in a myocardial infarct? It's a good question that I always forget. Your NSAIDs. Glucocorticoids. We literally give them aspirin though. Can increase your risk of rupture. Glucocorticoids, I remember that. Why do you not give someone glucocorticoids with an infarct? Why do you not give glucocorticoids in an infarct? It's glucocorticoid therapy. What? Yeah. It can cause hypertension. Yeah. What a tough question. Just go with it can increase your risk of rupture. Don't understand that too well though. Let's go back there. Let's go not biomed here. We'll go to BMJ. So we'll go to CAP. Damn. Heavy raining outside. Alright. Alright, finish cardio. Whoa, alright. Time to do a renal case. And time myself at that. Let's go timer. Don't start. Good. Might start with some renal. Maybe you'll start with a path. It's my most interesting section. And we'll go to BMJ. Let's open up some CAP. Let's go. Serious? Stuck with this? It's alright. Diabetic nephropathy. Regina's I might need to start a timer. I'm pretty hungry, so I might quickly heat up some food as well. I'll be right back with a snack or two. on the fork for no reason. Nothing better than pancakes. Protein pancakes while working. Right. You got Nutella on them too. It's pretty good. This time. Just get 10-minute timer. Okay. 20-year history. She's a 48-year-old with a 20. She's had diabetes since she was 28. She's got type 1 diabetes. You've seen her the previous day, arranged some urgent urine and blood tests. Okay. Might be doing a VBG, looking for any evidence of metabolic acidosis, ketosis, ketones in the urine. I'm going to compare his ankle edema to a mid-shin. And some swelling around the eyes. And she complains of foamy urine. Well, what are the causes of pedal edema? Okay, so I'd be concerned about causes of pedal edema. There can include causes such as causes of increased hydrostatic pressure in the vasculature, such as cardiac failure. Could be decreased oncotic pressure due to protein-losing enteropathy, nephrotic syndrome, nephropathy as she might have, as diabetes affects the kidneys. You'd also be concerned about causes of increased vascular permeability, such as inflammatory states, cellulitis, deep vein thrombosis, and rule out lymphedema and myxedema due to hyperthyroidism as well. Okay, that'd be a comprehensive analysis of her urine. So what is my most likely diagnosis? Most likely diagnosis is that of nephrotic syndrome, secondary to diabetes, so a diabetic nephropathy. I'd also like to exclude this is due to the presence of, so I need to always support it. Okay, my provisional diagnosis is that of nephrotic syndrome secondary to type 1 diabetes. This is evident through the evidence of facial and lower limb edema, which could indicate loss of albumin and proteins in the urine supported by the foamy urine she reports. My other differentials would be that of potentially cardiac failure secondary to long-standing diabetes, coronary artery disease. I like to also rule out other causes of pedal edema such as protein-losing enteropathies, cirrhosis, liver abnormalities, and rule out myxedema, lymphedema, and cellulitis/DVT. And how could you support the diagnosis? Well, you could support the diagnosis through getting a lipid profile, and you see hypertriglyceridemia in nephrotic syndrome. You'd see lower albumin, and you'd see protein in the urine. So proteinuria that's heavy, greater than 3.5 grams per day, is indicative of nephrotic syndrome. And should also be in a prothrombotic state due to losing antithrombotic factors, and should be in a immunocompromised state due to losing antibodies in serum. Oh, interesting. Proteinuria leads to decreased surface tension. That's what surfactants do, and that's why you get foams, right? Froth is due to decreased surface tension. Should probably research that. It's very interesting. That's from chronic pressure, period edema. Should have gone through the causes. Damn. Nephrotic syndrome is not its own diagnosis. Jesus. There are many causes of nephrotic syndrome. I should probably start that again. Cells. Huge. I didn't take big bites. god, what a good image. So you have the actual glomerular capillaries, and the mesangial cells, which are the supporting cells of this glomerulus, and you have the endothelium, then you have the glomerular basement membrane, then you have the podocytes and their foot processes that are external to the glomerular basement membrane, and they're all facing towards the Bowman's capsule. Wow. The body is so smart, so intelligent, the design. Mesangial cells, capillaries, podocytes, foot processes, basement membranes, and we have the parietal cells of the actual Bowman's capsule and the podocytes. Oh my god, that's amazing. No, what did I do? There we go. And we'll change 90 degrees HIV, and diabetic nephropathy, some infection, autoimmunity, membranoproliferative, which can occur due to lupus, tram tract, glomerular basement membrane infections, fenestrated systemic amyloidosis. Okay, so my provisional diagnosis is that of nephrotic syndrome due to the presence of ankle edema and a frothy urine, which indicates heavy proteinuria and resulting decreased oncotic pressures, resulting in extravasation of fluid into peripheral tissues. The cause of nephrotic syndrome could include diabetic nephropathy, could be amyloidosis. The most common causes are minimal change disease, commonly seen in children, and there is effacement of the foot processes of the podocytes observable in light microscopy. We also have focal segmental glomerulosclerosis, which can occur due to genetics, heroin, other infections, and we get damage to segments of the glomeruli, and there is damage to the podocyte foot processes in this process as well. We then have disorders of the basement membrane, which can result in nephrotic syndrome, such as membranous nephropathy, often seen in older individuals, 30 to 60 years old, and there's multiple causes, including lupus, can be hepatitis, can be syphilis, and certain medications, and it results in damage to the glomerular basement membrane, and there'll be a thickened glomerular basement membrane that's observable on microscopy. We also have membranoproliferative glomerulonephritis, glomerulonephritis, nephrotic and nephritic syndrome. So you can have membranoproliferative glomerulonephritis, which can occur due to lupus, can due to vascular conditions like granulomatosis with polyangiitis, and it can occur due to, and we also have, those are the main ones, right? What did I miss there? HIV, heroin, genetics, HIV for FSGS, and we get 85% during autoantibodies and membranous, right? And there's a thickened basement membrane, and there's hep, syphilis, malaria too, and there's cancers, autoimmune conditions, and drugs that I mentioned. So NSAIDs can cause a membranous nephropathy as well. Man, they cause so much. There's membranoproliferative glomerulonephritis, and there's fenestrated endothelium. Wow. Next question. and a sarca is severe edema. Periorbital, Merkey's lines due to hyperalbuminemia. Last, yeah. Protein should be quantified. 24-hour urine collection or spot urine protein to creatinine ratio. Carcinomas, renal ultrasounds is invariably performed before renal biopsy. Some isometric kidneys in FSGS, congenital renal dysplasia is invariably performed. Spot post-biopsy bleeding. Small scope needling renal arterial embolization or nephrectomy to arrest this. It is prudent to use imaging to assess the end-stage renal disease. Do we need to do any? So we do ultrasound, and we may do a CT abdo and a Doppler to look at flow. Variably done. ANCA, hepatitis, HIV serology, look for other causes of membranous nephropathy in AUCs. So Hep, HIV. Let's go back up. The causes. Hep, HIV. Cause FSGS. But we can also get Hep infection and cancer of the GI tract, causing membranous and Hep and HIV, FSGS. Yep, that makes sense. And Hep is membranoproliferative, so hepatitis can cause kidney problems too. Cause a membranoproliferative, or it can cause a membranous damage to the glomerular basement membrane. Okay, Hep. Alright. And what would I do? I'd do a urinalysis, 24-hour urine collection, and a urine to creatinine ratio, as it's roughly equivalent to the 24-hour urine collection results. If I get a value of 300 micrograms per okay, let me add that. Let me just put this back. no, 20 minutes already up. Reset that. Before we do, let me quickly finish this. 24-hour urine collection. Diagnostic test for nephrotic syndrome is you'd want to get 24-hour urine, right? So diagnostic is going to be your 24-hour urine collection. And you want to get more than 3.5 grams per day, and what the fuck did I just... Right. And you also, or you can get a urine protein to creatinine ratio. And it should be greater than 300 micrograms per... It's milligrams, right? Yeah, 3.5 per millimole? Yeah, milligrams per micromole. Micromole. Roughly equivalent to 24-hour urine. Right, so what investigations would I perform? Diagnostic is going to be 3 investigations. You're going to do 24-hour urine. You'd like to also get the urine to creatinine ratio. It's greater than 300 milligrams per micromole. And you'd like to also do a renal biopsy, which can tell you whether there is fibrosis, there is thickened glomerular basement membrane, tram tracks, as you would observe in membranoproliferative. Yeah, glomerulonephritis. You see the tram tracks in membranoproliferative. Okay. Let's make this bigger. Okay. I'll put this here, I'll put this here. I want keys notes too. So I should probably have keys notes here. Like this. Bring this out. We'll open this up and we will go medicine, phase 3, GEDMed, biomedicine science modules, phase 3, pathoma, GEDMed, biomedicine PowerPoint slides. Saving my backside. Let's see where nephrotic syndrome. First case. Okay. 24-hour urine, renal biopsy, like to also get EUCs, HbA1c, ANA, ANCA, due to it can also cause tram track, ANCA vasculitides, and kidney ultrasound, and CT and a Doppler. What? Well, I will download it, but like why? What happened there? Okay. No, that's not it. What is this? This is what I did. To these I was explaining. Sheesh. No, don't save. Don't tell me that you can't view his cases anymore. No, it's all there. Acromegaly, all here. And what's happening to nephrotic, ischemic, lymphoma, diabetic nephropathy, nephrotic syndrome. It's case protocol too. Regina. Generalized edema, minimal change of FSGS, about DVTs, hypothyroidism, bedside, proteinuria, lipids, fatty casts, 25 is deemed impractical, LFTs, yep, lipid studies, And you would like to also get an ultrasound. It can be larger kidneys than normal. It can be hyperfiltration, and you do Doppler studies, and renal biopsy is your diagnostic investigation. And you'd confirm nodular sclerosis given type 1 diabetes mellitus history. Describe the main features and function of the glomerular barrier. Okay. And the glomerular space is capillary endothelium. There is a glomerular basement membrane, and there is the podocytes with their foot processes, and there are what is the actual definition of a renal corpuscle? It's a Malpighian body. It is a filtration unit of vertebrate nephrons. It consists of a knot of capillaries surrounded by the Bowman's capsule that opens into a tubule. That's the Malpighian body. The Malpighian body or renal corpuscle, which is the glomerulus, the Bowman's capsule. Oh my sheesh. Glomerulus plus Bowman's capsule plus afferent plus efferent arterial is known as the renal corpuscle or Malpighian body. Okay. Let's all copy this. Copy. Paste. Make that bigger. There we go. Why is it so blurry? Those are your mesangial cells, right? And they between the glomerular capillaries and the producing mesangium, which consists of basement-like material which gives structure to the glomerulus. That makes sense. And there's layers to the filtration barrier. You have the fenestrated capillary endothelium, right, that are nanometers in size, and fluid and plasma proteins are filtered across, but not red blood cells. And the basement membrane consists of the lamina rara interna, the lamina densa, and the 5 years med school, don't you remember learning that? Lamina, there are 3 lamina layers for the basement membrane, made up of collagen and glycoproteins, and it does not allow the filtration of plasma proteins. Other proteins can filter across the capillary endothelium, but not the basement membrane. And then you have your podocytes, which are your visceral epithelial cells, right? Because you have parietal epithelial cells of your podocytes and pedicels. That's part of technically the Bowman's capsule. Podocytes are part of the Bowman's capsule, technically. Yeah, right. And there is a parietal epithelial cells as well. So they're the visceral epithelial cells. And there's filtration slits that exist between each foot. Right. Foot process is 16 nanometers in diameter. So how good my memory is there. 25 to 60 nanometers in diameter, and these pores are 70 to 100 nanometers in diameter. The capillary endothelium, 60 to 25 to 60, 70 to 100. Basement membrane and podocytes are the most important. It continues with parietal epithelial cells, the Bowman's capsule. And negatively charged glycoproteins are present on all 3 layers, and they repel positively charged plasma proteins from being filtered. And both charge and pore size prevent. Wow! 70 to 100, 25 to 60, 70 to 100, 25 to 60. Okay. Alright, let's see how good the memory is now. Okay, the glomerular filtration barrier consists of the renal corpuscle, which is comprised of your glomerulus, your Bowman's capsule, and your afferent and efferent arterioles. The renal corpuscle is also known as a Malpighian body. The glomerulus consists of endothelial cells and mesangial cells, which form the connective tissue-like structural component of the glomerulus. Your glomerular endothelium consists of fenestrations that have pore size of approximately 70 to 100 nanometers in size. External to the endothelium is your glomerular basement membrane, and the glomerular basement membrane consists of connective tissue proteins such as collagen. Now, your capillary endothelium allows all structures except red blood cells to pass through, whereas the connective tissue basement membrane does not enable proteins to pass through due to its pore size. We then have your foot processes, and the foot processes belong to podocytes that are also known as visceral epithelial cells. Visceral epithelial cells, podocytes, and they continue to the parietal epithelial cells, which will form the Bowman's capsule. The visceral epithelial cells have slits between their foot processes, and these slits are approximately 25 to 60 nanometers in size, and they will define a filtration barrier, and they will enable all substances to pass through except your red blood cells and large proteins. All three layers have negatively charged glycoproteins, and thus they repel positively charged serine proteins. And so proteins are normally not filtered across due to large size and charge. However, up to 3 grams of protein can be normally excreted in the urine. More than 3.5 grams in a 24-hour urine sample is diagnostic or characteristic of nephrotic syndrome. Ultimately, diagnosis is based upon renal biopsy. Not bad. Next question. What investigations would I order for this patient? Okay, so we'll start with this. A patient who has facial edema and proteinuria. Given the presence of facial edema, which indicates decreased oncotic pressure, and proteinuria, my primary differential diagnosis is that of nephrotic syndrome. Nephrotic syndrome can be secondary to diabetes, can be caused by amyloid, it can be occurring due to minimal change disease, which is commonly occurring in children, and there is effacement of the foot processes of your podocytes on electron microscopy. We can also have focal segmental glomerular sclerosis, which can occur due to HIV, heroin, or genetics, and we have damage to the podocytes in this disease as well. And there is only damage to segments of the glomerulus. And then we have basement membrane disorders, and these can include membranous nephropathy, commonly seen in elderly people 30 to 60 years old. It can be caused by multiple reasons, such as infection, it can be hepatitis, it can be syphilis, it can be malaria, it can be schistosomiasis. It can also occur due to lupus, autoimmune conditions, and about 80% of patients, more than 85% of patients with membranous nephropathy have autoantibodies to the glomerular basement membrane, and we observe thickening of the glomerular basement membrane, and we also have membranoproliferative glomerular nephritis, which can also occur due to lupus and vasculitides, such as granulomatosis with polyangiitis, and also infections such as hepatitis, which can damage the glomerular basement membrane. So basic investigations I would order. Bedside, I'd like to order urinalysis, looking for heavy proteinuria greater than 3.5 grams. Heavy proteinuria, sorry. Urinalysis can't really quantify it. So I'd like to get urinalysis, looking for heavy proteinuria, and I'd also like to get urine microscopy culture, looking for evidence of any casts that are also present, which indicate glomerular disease. And I would like to also observe for either a 24-hour urine collection, looking for over 3.5 grams of proteinuria. I'd like to get a urine protein to creatinine ratio that's greater than 300 milligrams per micromole of creatinine, and that's equivalent approximately to the 24-hour urine collection. I would then like to get basic laboratory investigations, full blood count, CRP, ESR, to look for any signs of infection that could be indicative of HIV or hepatitis. I like to get EUCs to look at baseline kidney function, glomerular filtration rate, and LFTs, as hepatitis can also affect your renal function. I'd like to also get serology for HIV, hepatitis, and I'd also like to get an ANA panel, autoimmune panel, to look for any evidence of vasculitides, and then proceed to getting. I might like to also do lipid profiles, as nephrotic syndrome can cause lipid derangement. I'd like to maybe also get a coag done, such as INI-APTT, as nephrotic syndrome can cause a prothrombotic state, and I would then proceed to imaging investigations such as my ultrasound, and I might like to do Doppler studies as well, looking for any evidence of any renal dysplasia, any renal artery hypertension, and I would like to also do a CT abdomen if required. And my diagnosis is equivocal, I'd also do renal biopsy, which is your confirmatory investigation. And with diabetes, you would observe nodular sclerosis. Yes, okay, need to be much shorter, much shorter, but I got the gist. Who's surviving? Hi, Norsky. Good luck. Hardest part about med school is getting in. Actual med school is not that hard. Yeah, this stuff is really cool because you use it to save patients' lives and take care of people who have critical conditions. It's an amazing course. Okay. So if I restart for my investigations, I guess the structure of the investigation would be to look for causes and look for complications, right? But I need to do that simultaneously, which is a challenging part. So with this condition, I would like to do set a 2-minute timer for every answer. I'll do it at the end. I've done that. And a cholesterol blood test reveal an albumin, which is low, a cholesterol, which is high, dipstick, which is high. How did this protein reach the urine? What are the main types of proteins to be present? Okay. Right. You get increased GFR, and then after 5 years, you'll get diffuse mesangial sclerosis. Increased proliferation of mesangial cells, thickening of the glomerular basement membrane, nodular glomerulosclerosis. There's only 30%, and you get ball-like deposits of matrix in the glomerular capillaries. Kimmel-Steele-Wilson lesion. Spore-like deposits. Diffuse mesangial sclerosis, thickening of the glomerular basement membrane. both lesions, GFR. You get GFR after 5-10 years. There's a group of 5 years. Kimmel, Steer, Wilson lesions. Alright, let's see. What's the next question? Yeah, massive proteinuria, damage to the filtration barrier, increase the glomerular permeability, leakage of plasma proteins, and into the urine. If the defect is large, unless erythrocytes can also pass through, which indicate significant glomerular disease. The main proteins lost is albumin, and you also lose vitamin D binding proteins, causing vitamin D deficiency. Immunoglobulins, transferrin. And you can lose transferrin, which is your iron-binding protein, which you get a microcytic hypochromic anemia. And you get antithrombin 3 to hypercoagulable state. Right off. Transferrin. Right. Proteinuria. Bind to macrophages. Bind to receptors for advanced glycated end products and endothelial smooth muscle, and you get the smooth muscles, you get those proteins to pass through. Right. You also get AGs cause cross-link extracellular matrix proteins. They can trap albumin. Advanced glycated end products. There's advanced glycated end products which also bind to receptors. They can activate macrophages, they can reactive oxygen species, proliferation of smooth muscle, and they can cross-link extracellular proteins which trap albumin in the glomerular capillary walls, and they can reduce the negative charge of the basement membrane. Albumin is the main circulating protein. Yeah, we get that, but explain the pathophysiology. Starling's equation. When did I last look at this equation? So this is telling me that the flux across the vessel wall is equal to the filtration coefficient multiplied by the capillary hydrostatic pressure. What? Forgotten the equation. How I forget Starling's equation? Proteinuria, membranous, minimal change, FSGS, systemic, lupus, drugs, infections, proteinuria, diabetic. His name, loss of glomerular. Selected proteinuria. Charge. Gated end products. Reduce the negative charge. Reduce charge. Falls, edema, drops in narcotic pressure, instead of Starling's forces, there's widespread edema, excessive aldosterone production, aldosterone trigger. Ascites, pulmonary edema, pleural effusion, anasarca, hyperlipidemia, which causes LDL, VLDL, nephrotic spectrum, nephrotic syndrome. Nephrotic syndrome is oliguria, uremia, protein, hypertension, and yes, that makes sense, right? We've got lupus, can cause everything, FSGS, membranous nephropathy, diabetes. And here we got so many other causes. Inflammation, stress inflammation. Alright, case protocol. We'll go through the case protocol. 43-year-old has swelling of the feet and ankles. She has a 13-year history of severe seropositive rheumatoid. Right, there's bilateral pitting ankle edema and symmetrical polyarthritis, which is consistent with rheumatoid. Symmetrical polyarthritis and its small joint. Pitting edema, Bouchard's inhabitants. Bouchard's are proximal, right? Bouchard's notes. No, it's distal. It's Bouchard and then habitant. If you read your... No, it's right. Have it here. Right. Bouchard's inhabitants. Treated with answers with rheumatoid arthritis treated with gold. Gold is a treatment. We tripping. Apart from mild hypertension, the remainder of the physical exam was normal. Heart rate is normal, blood pressure is high, respirate is normal, temp is normal, urinalysis protein is very positive, and blood is negative. This looks like a nephrotic syndrome picture. There is hyponatremia, there is no potassium, chloride, bicarb, normal. Urea is slightly elevated, creatinine is on the elevated end. And what is it asking? What clinical syndrome is this? Yes, it's nephrotic syndrome. How would I substantiate it? I would look for 24-hour protein, look for 3.5 grams. Greater proteinuria, or I'd like to get a urine protein to creatinine ratio that's greater than 300 milligrams per micromole. Right, and how would I also substantiate it? I also look for serum albumin. I'd see lower serum albumin levels, and I'd like to also do LFTs, lipid profile, cholesterol levels. Right, yeah. Albumin is with LFTs, not with the UCs, with the LFTs. What are the relation between patients' proteinuria and ankle edema? Loss of protein, decreased serum albumin, decreased colloid osmotic pressure relative to intravascular pressure. Decreased colloid osmotic pressure. Yep. Reduction in intravascular volume is going to activate the RAS system, and there is also going to be decreased hypovolemia, atrial natriuretic peptide, causes natriuresis and sodium loss, but since we are losing fluid, we are going to get decreased natriuresis. Sodium will build up and retain fluid. Intravascular volume, because fluid is leaving. Loss in hepatic synthesis. Oh my god. Thromboembolism with the complications. Edema, hypovolemia. Thromboembolism. Infection. Cardiovascular disease. Vitamin D deficiency as we are losing vitamin D binding proteins. Anemia. Yes, due to decreased erythropoietin production, but also loss of transferrin, which is a binding protein. Sheesh. She's on treatment. What could be the patient's be drug treatment? Yes, NSAIDs can cause a nephrotic syndrome, and they can cause interstitial nephritis or papillary necrosis. Interstitial nephritis or papillary necrosis. And gold and penicillin also recognized as causes. and spikes. Thickened glomerular based membrane, but spikes protruding from the glomerular capillary wall between the subepithelial deposits. In with a silver stain. With a silver stain, we'd see glomerular spikes. And you'd see effacement of the foot processes of podocytes. And IgG and C3 deposition. Granular deposition of IgG and C3. Effacement of the foot processes. Right. Yeah, the foot processes are effaced. And there is deposits. Minimal changes. Everything is normal except this effacement of the foot processes. Membranous. Slit diaphragms. Loss of slit diaphragms. It's not a fusion of the visceral. It's effacement. Flattening and swelling of the foot processes. Flattening and swelling. Histology. Light microscopy. This would be lipid vacuoles in sclerotic areas along foam cells. Must be lipid vacuoles in sclerotic areas along foam cells. Diffuse effacements of the podocyte foot processes. Light focal and segmental lesions affecting a minority of the glomeruli. Can be missed. There's hyalosclerosis. Plasma proteins depositing in the capillary wall. Plasma proteins. And there's IgM and IgG and C3 membranous and IgM and C3 in immunofluorescence for FSGS. Thickens and it shows a tram track appearance. It's thickened. Shows a tram track. Frick. Is it just me, or where are we seeing the tram tracks? Is that it? Tram tracks. That might. So what am I seeing here? This is one glomerulus, right? No, this is part of the glomerulus. I'm seeing endothelial cells. What's going on? No, not tram tracks on a chest x-ray, not actual tram tracks. Kidney. Help. Yeah, okay. Tram tracks in membranous proliferative. I'm not going to forget that because I've never seen that in my life. Duplication of the basement membrane. Yeah, it just doubles on itself. New basement membrane synthesis due to immune complex deposition. Glomeruli large, hypercellularity, and there's a lobular appearance. I'm not going to get that. Spikes, and there's going to be glomerulus with spikes. Silver stain, representing the double contour. 1, 2, I think I see it, yeah. And a double contour, yep. Yeah, it looks, yeah, okay, that makes sense. I think I'm seeing it, yeah, it's characteristic of MPGN. Right, remember type 1, an immunofluorescence, membranous type 1 viewed by light microscopy left, and immunofluorescence. Type 1 glomerulus. Secondary causes, drugs, acilian cancers. Membranous nephropathy can occur due to infections such as hepatitis, malaria, syphilis. Can occur due to medications like NSAIDs, mercury, which is a toxin, and cancers, gastric cancers. We see bowel malignancies, bowel and tumor-derived antigen, penicillin, syphilis, malaria, lupus. Oh, that was a hard case. Oh, in 20 minutes. Any med students helping out? No. Just me. Net fluid flow, filtration coefficient, capillary hydrostatic minus capillary oncotic. No, it's capillary hydrostatic minus pious oncotic. And interstitial. Plasma oncotic minus interstitial. Starling equation. Filtration coefficient describes the membrane's permeability to border, bracket, the capillary hydrostatic pressure. It should be higher than the interstitial. Yeah, that makes sense. Interstitial hydrostatic pressure. Out. And interstitial hydrostatic pressure. Yep. And there is oncotic pressure. There is capillary oncotic pressure. The more protein, which is just due to proteins. So loss of proteins will decrease capillary oncotic pressure. That's going to cause leakage. Makes sense. Okay, am I ready to answer all of these questions? No. What you mean, no? Answering all of them, boy. 8 minutes. Let's see how we go. How do you hide this? Let's go back. There we go. Let's go. Yeah, I'll make this longer in case you make sure you can all still hear me fine. Face me here. Alright, Regina's a 48-year-old with a 20-year history of type 1 diabetes. Let's start a timer here. 8-minute timer. She is a 40-year-old with a 20-year history of type 1 diabetes. You've seen on the previous day arranged some urgent urine and blood tests. Main complaint is ankle swelling up to a mid-shin for the first few hours and swelling around her eyes. Complaints of foamy urine. What is your likely diagnosis? My provisional diagnosis is that of nephrotic syndrome secondary to diabetes, so diabetic nephropathy. My other differentials for nephrotic syndrome could be common causes such as minimal change disease, membranous membranous nephropathy, focal segmental glomerulosclerosis, and membranoproliferative disease. It could be secondary to lupus, ANCA vasculitis infection. I also like to rule out amyloidosis causing nephropathy, nephrotic syndrome. Other differentials for pedal edema would be that of cardiac disease, liver cirrhosis. It could be bilateral DVTs, cellulitis, for example. What investigations would I perform? I would perform bedside. I'd like to do, my diagnostic investigation of choice would be that of a renal biopsy. However, prior to that, I'd like to begin with laboratory and bedside investigations. Bedside investigations could be 24-hour urine to creatinine rate, 24-hour urine protein, which is aiming to quantify proteinuria. I'd like to see more than 3.5 grams per day, which is diagnostic, which is indicative of nephrotic syndrome. I would also like to do urine to creatinine ratio, which can be used as a surrogate marker, as it's equivalent to the 24-hour urine protein. I'd like to also get urinalysis, looking for evidence of any hematuria, any proteinuria, and their relative degree. Bedside investigation, I'd like to do a full blood count, ESR, CRP, looking for signs of infection, which could cue me into HIV, hepatitis as some causes of nephrotic syndrome. I then like to do EUCs to assess kidney function. I also do LFTs, look at albumin as it will be low in nephrotic syndrome, and also like to do lipid profile to look for evidence of LDL and VLDL increase. I would also potentially like to do coags as they may be in a prothrombotic state due to antithrombin inhibition, and I may also like to do a renal ultrasound and renal Doppler studies, followed by CT abdo and renal biopsy. Main features of the glomerular filtration barrier include glomerular endothelium and mesangial cells, which is the connective tissue component of the glomerulus. The glomerular endothelium, which consists of fenestrations, which are approximately 70 to 100 nanometers. And we also then have the glomerular basement membrane, and the basement membrane consists of matrix proteins such as collagen, and then we have our podocytes, and their foot processes. And the podocytes are also known as your visceral epithelial cells, and they reflect to form the parietal epithelial cells of your glomerular Bowman's capsule. And that forms renal corpuscle, which is a glomerulus, Bowman's capsule, and the efferent arterioles. The function of the glomerular filtration barrier is to prevent to enable selective filtration, and it does this through pore size, in which the foot process of the podocytes and the basement membrane do not enable large proteins to pass through, and none of the three layers enable red blood cells to pass through. And they consist of negatively charged glycoproteins in all three layers, which prevent the entry of negatively charged proteins such as albumin into the nephron tubules. The patient has albumin of 18, cholesterol of 8.2, and dipstick is high protein. What are the main types of protein to be present? Okay, the protein must have reached the urine due to compromise out of one of the three layers, or multiple of the three layers, for the glomerular filtration barrier, and minimal changes these. It's the effacement of the foot process of the podocytes. Focal segmental glomerulosclerosis, there is damage to the actual glomerular endothelial cells and the foot processes of the podocytes, and membranous nephropathy. There's thickening of the glomerular basement membrane, spike proteins, and loss of cell activity as well. We also lose negative glycoproteins in three layers, which will enable albumin to also pass through due to charge. Main proteins present would be albumin, as it is passed through from the bloodstream, and as albumin is low, there will also be antithrombin 3, which is one of the main clotting factors, and that's why the patient's in a high coagulatory state. There will also be immune proteins, your antibodies, immunoglobulins, which will pass through to put the patient in an immunocompromised state. And there'll also be transferrin, which can cause microcytic hypochromic anemia, vitamin D binding protein, which can cause vitamin D deficiency, and we also have I can think of. In the pathophysiology of a woman's edema and her lipid changes. Well, her edema, due to damage at the glomerular, at the renal corpuscle, there has been albumin, which has then passed through the Malpighian body. As a result, we have loss of albumin, and the liver will compensate by synthesizing more albumin. However, it can only do so for a particular range of time, followed by we lose this compromised function and we get decrease in serum albumin. This will drop the oncotic pressure, and this will be a driving force for extravasation of fluid as we disrupt Starling's equation. And as a result, we get extravasation of fluid, we get edema, and this edema can occur in multiple parts of the body. It can occur in the lower limbs, the face, it can also progress to causing pleural effusions, ascites. The lipid changes are due to compromise by the liver to also increase the number of lipoproteins in an attempt to maintain oncotic pressure, and it produces LDL and VLDL in this process as well. What is Starling's equation? Starling's equation, which explains the net flow, is equal to the filtration coefficient multiplied by, and then in brackets we have our capillary hydrostatic pressure minus your interstitial hydrostatic pressure, and that will be driving fluid out. And then we have minus, and we have our capillary oncotic pressure minus your interstitial oncotic pressure, close brackets, times your reflection coefficient. And this basically explains that when you have a positive hydrostatic pressure in your capillaries and a positive interstitial oncotic pressure, you'll get a net filtration, and that will mean the net filtration is positive. Net filtration value is negative, we don't get filtration, we get fluid actually moving into the vasculature. That's it. Oh, that was a long-winded revision. What causes each of the nephropathies? Well, minimal change disease, effacement of the foot processes of the podocytes. It's often reversible through steroids. And then we have FSGS, which can occur due to heroin, it can occur due to HIV, it can occur due to genetics. And then we have our membranous nephropathy, which can occur due to many reasons, such as membranous nephropathy can occur due to infections, and it can occur due to lupus, it can occur due to ANCA vasculitides, it can occur due to bowel and bronchial cancers, and it's characterized by spike formation and thickening of glomerular basement membrane. Membranoproliferative disease, you may observe in electron microscopy there is tram tracks, which is two glomerular basement membranes formed due to antibody immune complex deposition. Sheesh. Let's readjust this. Alright, finish one renal case. I am done with renal for now. With path. It was just nephropathy. I've done renal path. Let's move on then to biomed. Let's go to gastro. And then we'll do one resp. Gastropath. It's a very common colorectal carcinoma. Cholecystitis would be a really good one. IBD, fever of unknown origin. Yeah, I'd say that would be really good. Cholecystitis, that would be very good. I actually spent $600 on textbooks in first year. It was probably the biggest mistake of my first year uni. I actually don't really use textbooks. I use these are all student notes that past students have used that have gotten top of their class in their exams. But Robbins is really good for path, I've heard. And for pharma, I don't use any textbooks. Honestly, pharma is just looking at lecture notes and all. Where can I practice clinical cases? If you want to do that and practice differentials, I can send you my 5th year biomedical exam cases. They're all like the main cases you would need to know to be a good junior doctor. There's about 100 cases. And there's also 6th year cases as well, which are pretty much management cases. I can send that across as well if you want. You just message me on social media. I'll message it too. I might take a quick 1 minute break, I guess, just to breathe before going through the next two cases. That was hefty. So, taking a break now, so I'm not doing any medical study. Doing those, and then here. Yeah. Oh, sheesh. If your clinic experience is not good, that sucks because your examination skills probably make up the most of being good. Your history skills as well. I'd recommend, I think these cases are really good. They get you to think in terms of differentials and that guides your history taking. For sure. I'm currently in isolation. Otherwise, I wouldn't be studying till this late because I have hospital usually at 7 or 8 in the mornings. But yeah. Jeez Christ, man. Jeez Christ. Jesus Christ. Nope. Nope. weird. Alright. Let's get back on the grind. I need to just close the chat. Okay. Acute cholecystitis. And I'll open that up here as well. Acute. Same thing. Okay. I don't know what I ate. I'm full. Let's go. Timer. 20-minute timer. Oh, 12-minute timer. Student presents ED with an 8-hour history of severe upper abdominal pain, which radiates around to her back. Upper abdominal pain, which is radiated around to her back and caused nausea and vomiting. On examination, she was distressed by the pain with tachycardia. She's got fever as well and tenderness in the right upper quadrant. She has a past history of episodic epigastric pain, which on one occasion was accompanied by jaundice. Need anything? I'm just gonna write normal. Urine pH is 5.8. And without looking at all of that, bring it back up. Alright. What is my provisional differential diagnosis? My provisional diagnosis is that of given right upper quadrant pain radiating to her back. I am concerned about cholecystitis, biliary colic, and my differentials, I'd like to write life-threatening causes of upper abdominal pain, which could include a duodenal gastric ulcer. Also like to exclude lower lobe pneumonia, acute coronary syndrome such as myocardial infarct. Also on that note, also write aortic dissection, upper abdominal pain given tachycardia. Also like to rule out AAA, and my other differentials would be that of a pancreatitis, pyelonephritis, diverticulitis given the patient's age. Let's see what we got here. Yep, biliary pain that's progressively worsened, severe upper abdominal pain radiated to a back, nausea, vomiting. Let's see what this says. It's got an image. BMJ's got an image. You kidding me? That's so cool. Alright. Okay, due to cholelithiasis. Symptomatic also the common for developing cholecystitis. Right of quadrant. Appendicitis. Imagine the laugh I'd get. Evidence of systemic inflammatory fever, white cell raise, CRP. Ultrasound is a definitive initial test, and then you can do an MRCP, magnetic resonance cholangiopancreatography may be required. Use CT. CT, suspected sepsis. Treatment is antibiotics, analgesia, and fluid resusc. Likely to be followed with an early cholecystectomy. It develops in 10% of patients. In most patients, 90% is caused by complete cystic obstruction. Cystic duct obstruction. Right, so we've got the left and right hepatic ducts, your common hepatic duct, kinds of your cystic duct to form your common bowel duct, and that empties into the ampulla of Vata, or the major, which joins, yeah, ampulla of Vata, the major pancreatic or duodenal duct. Yep. It's the interscapular, right scapula or right shoulder. Cholecystitis, it radiates to the interscapular or right shoulder. So acute cholecystitis radiates to the right shoulder, and that's the giveaway of this case. There's nausea, vomiting, low-grade fever. 70% have a prior biliary colic. The risk factors for cholecystitis are the F's: 40s, fat, female, fertile, fat, fertile, fair, and family history. 40 fat, fetus, fair, family history. 40 fat, fetus, fair, family history. Interesting. Let's go back. Let's go to not pleural effusion. Let's go to not fever of unknown origin. Where are the rest of the damn cases, man? Cholecystitis, man. There we go. Let's go. Differentials. Ascending cholangitis, fever, right up quadrant pain, and jaundice. That's a triad, right? Of cholecystitis. Yes, we said that. Peptic ulcer. Yep. Consider small bowel obstruction, gastroenteritis. MI and a AAA, which I got. I'm pretty good diagnostician then. That's anatomical and pathological basis. So what did I miss? That's what I should be focusing on. Ascending cholangitis, I didn't mention, and small bowel obstruction, gastroenteritis. Hepatitis, pancreatitis. Anatomy. What is the anatomical and pathological basis? Current presentation. She's got diffuse midline epigastric pain because there's irritation of the visceral peritoneum that's lining the gallbladder. And we start getting a localized sharp pain due to irritation of the parietal peritoneum. So initially we have the visceral peritoneum is a poor localizer of pain. You see that in appendicitis too. You get this diffuse just epigastric umbilical pain that will then radiate to the McBurney's point, right? Which is 1/3 from the umbilicus to the ASIS. Right. So we start getting sharp pain due to irritation of parietal peritoneum. And if the gallbladder irritates the liver capsule, we get Boas sign. That is Boas sign, pain radiating to the right scapula. And that's because the diaphragm is innervated by the phrenic nerves C3, 4, and 5. Yep, if it is the liver capsule and the diaphragm, we get pain radiating to C4, 3, 4, 5, and that confuses the pain with those dermatomes. Let's see what dermatomes that is. If that's scapula, yeah, y'all gotta be kidding me. C3, C4, C5 is your neck. Not interscapular dermatomes. Should be front. Oh no. Dorsal spinal and sensory cortex. It confuses the incoming signals and the right hemidiaphragm. So Boas sign, diaphragm innervated, dorsal spinal sensory cortex. Sensory cortex confuses it with the right hemidiaphragm. Yeah, okay, it's a hepatopancreatic ampulla, major duodenal papilla, the ampulla of Vata, ampulla which drains into the major duodenal papilla. There is a minor duodenal papilla and a major duodenal papilla. The ampulla of Vata drains into the major duodenal papilla. There is the infundibulum, and there is the fundus, which is fundus, body, infundibulum. So there's a narrowing. Fundus, body, neck, infundibulum, neck, and then there is your cystic duct to the right, and your common hepatic duct, pancreatic duct, ampulla, vata, Bowers sign. No clue what Bowers sign is and how that makes sense, but let's see if it makes sense when I do this. Right. Put it here, pal, and here. I've got 2 minutes left, come on. Sonographic, Murphy sign, stones, acoustic shadowing, pericholecystic fluid, the gallbladder distension, wall vascularity with Doppler, urinalysis, hematuria, pyelonephritis, pregnancy as well, and the ECG to exclude acute myocardial infarct. If there is a LFTs, biliary obstruction, there'll be raised GGT, EUCs, blood cultures, usually gram-negative organisms. Could do a HIDA scan, which was using technetium-99, and do MRCP and an ERCP, cholecystolithiasis, or endoscopic rupture. It's a treatment. ERCP is therapeutic for cholecystolithiasis, which is stone, which is majority of the times the case. Septicemia, very colic, gallstone formation due to an imbalance of cholesterol and its solubilizing agents. I don't want to know that. I want to know, gallstone formation, imbalance of cholesterol and its solubilizing agents, which is bile salts. Imbalance of cholesterol and its bile salts, so cholesterol will precipitate and lecithin, which is a protein which solubilizes bile salts, and that will usually show cholecystokinin to cause gallbladder to contract. So after a fatty meal we get the cholecystokinin, which causes gallbladder contraction in response to a fatty meal. And the pain is caused when the gallstone transiently impacts in the neck of the gallbladder or the cystic duct, or the common hepatic duct, or the common bowel. Sheesh. Okay. Pain is caused when gallstone transiently impacts in the neck of the gallbladder, the cystic duct, or the common hepatic duct, or the common bile duct. Pain is caused when the gallstone transiently impacts the neck of the gallbladder, the cystic duct, common bile duct, cholecystokinin. Obstructive jaundice due to gallstone, obstruction of the bile duct, bilirubin build-up, leak into the blood, jaundice. Hartmann's pouch. Cystic duct to Hartmann's pouch, which is a region to the infundibulum of the gallbladder. Bowel stagnation. Lecithin is converted to toxic lysolecithin. As disruption of the mucus layer. Mucous epithelium is exposed to bowel salts, which can emulsify fats. Mucosal epithelium is exposed to bowel salts, which can emulsify the fats. Which can emulsify prostaglandin. So lecithin is converted to toxic lysolecithin. There's disruption of that mucosal layer, and the mucus is exposed to bowel salts, which can emulsify fats, damaging it. We get the release of prostaglandins, inflammation, and we also get distension, increase in intraluminal pressure, which compromises blood flow, ischemia, distension, increase in intraluminal pressure, which is going to decrease blood flow, ischemia, necrosis, to the right upper quadrant, producing a localized peritonitis. Pain occurs in the right hypochondrium. The right Man. Dumb. Quadrant. Yeah, what does it mean in terms of anatomy? Why? I know what hypochondriac means, but why is it called left right hypochondriac regions? 5 years of med school, I asked myself that question. Right hypochondrium, T7 to 9 dermatomes. It would be felt at the shoulder tip because it irritates the diaphragm. The phrenic nerve sends signals to the phrenic nerve sends signals. There's a confirmed prior to diaphragm or dark phrenic nerve branching to the gallbladder. Inflammation, phrenic nerve. So they'll found at the right shoulder tip areas there can be phrenic nerve involvement due to inflammation. Yes, okay. Biliary, right hepatic, left hepatic, gallbladder, cystic duct, intrahepatic, pancreas, common bile duct, ampulla, vata. What did the biochemistry reveal? Yep. But what's the what? If they gave me bicarb is low, then what's the pH, man? The urea is high. There's hyperuricemia. And there's elevated bicarbonate, which could indicate decreased bicarbonate, which could increase a metabolic acidosis. Like to also get a lactate if I could. Maybe sepsis. Creatinine is low. Normal. Bilirubin is high. There's hyperbilirubinemia, and there is raised AOP, GGT, which reflects a biliary pattern of obstruction. Dehydration due to vomiting, lactic acid, dehydration due to vomiting, and bicarbonate has decreased bicarbonate. What? Well, I've really see the following biochemistry results indicate bilirubin mild cholestatic pattern. Early obstructive jaundice due to edema of the bowel secondary to cholecystitis or transiently passing gallstones. Larger increase in bilirubin. Normal transaminases. Normal synthetic production of liver hepatocyte damage or hepatitis. And there is a lactic acid. What is going on? Gallstones, transaminases, synthetic production of liver, urea, dehydration due to vomiting. Yep, that makes sense. And the vomiting causes poor tissue perfusion, building lactic acid up. Yes. In acalculous cholecystitis, it's rare, specifically in unwell ICU patients. Kind of gallbladder stasis, biliary sludge, and cholesterol microcrystals and viscous bile. It can be it's known to be caused gallbladder stasis, and there's accumulation of cholesterol microcrystals, which can make the bowel very viscous, and that can be obstruction. And a cystic artery, which is an end artery. Cystic artery is a branch of the right hepatic artery. Trauma, burns, severe sepsis, prolonged stay can also cause the biliary fluid to become more viscous, and cholesterol microcrystals can precipitate. Except for the absence of stones, ultrasounds measure sludge or small stones. Broad spectrum antibiotics on the same. Cholecystectomy. Shock, whether it's due to sepsis, shock, hemorrhage, use vasopressors, decrease splenic blood flow. Whew. It's hefty, man. Complications, case history. Oh my god, so hefty. Shock. So normally there is the ice prolonged starvation, the absence of normal cholecystokinin and bladder contraction that causes bowel stasis. You get bowel stasis, distended bladder, concentration of bowel salts, bowel gets very viscous, cholesterol can be intivorous, bowel can get very viscous, distended gallbladder, it's highly concentrated bowel salts become viscous, and that can cause and certain shock. So sepsis can decrease volume depletion. A calculus. What are the complications? Well, get gallbladder mucocele, which is high drops of fluid build up in the gallbladder. Pancreatitis, especially ampulla ovata. Obstruction progresses to the ampulla ovata. You can also get a pancreatitis. Obstruction of the cystic duct can cause gallbladder mucocele or high drops. You can also get pancreatitis and Klebsiella, usually gram-negative, such as Klebsiella E. coli and Enterococcus. You get empyema, gangrene, or an ascending cholangitis can occur as a complication of cholecystitis. And perforation, peritonitis, chronic carcinoma, and carcinoma of the gallbladder, Enterococcus, Klebsiella, E. coli. Analgesia, antibiotics, selective cholecystectomy, NSAIDs cause less spasm of the sphincter of Oddi than morphine. Analgesic, usually NSAIDs rather than morphine, because they cause less spasm of the sphincter of Oddi. What is the sphincter of Oddi? Sphincter of Oddi. Let's come back here. Okay, good. Why does everyone have a name in medicine? Sphincter of Oddi is right, so you have the major duodenal papilla right there, and your sphincter of Oddi right there. Right, the duct of Wiersung is... It's just a duct. Pancreatic duct. Come on. You're joking. Right, so let's come back here. Acute cholecystitis. Yep, because of spasms in the sphincter of Oddi. Acute cholecystitis. Antibiotics is not usually infected, occurs due to inflammation spreading to the serosa, but superimposed infection can occur. Yeah, Klebsiella E. coli from the gut. So it's not as much infection as appendicitis is, right? With appendicitis, you give them an antibiotics, but it can be from the anaerobes, right? Gram-negative anaerobes, Klebsiella, Bacteroides, anaerobes of biliary obstruction is present. Klebsiella, E. coli from the gut, community mod. You can ceftriaxone, non-enteric cefuroxime. Just gonna say ceftriaxone. Why do I need to memorize all of that? And if the obstruction is present, anaerobic carbometronidazole should be added, and broad spectrum should be used. Uncomplicated cholecystitis, and if there is biliary obstruction, you can also give anaerobic cover, as it can be anaerobes, Klebsiella from the gut. Yeah, okay. So ceftriaxone, but if it's anaerobes, you then put them on a broad you could put them on metronidazole, for example, and you'd add a broad spectrum, such as a penem. And gallstones are removed and given to the patient as a memento. What's the likely composition? What are the types of gallstones? They're going to be mixed cholesterol, calcium carbonate, phosphates, and bilirubin. So cholesterol precipitates, and there's bile salts and lecithin, which usually dissolves. It says excess of cholesterol, calcium carbonate, and calcium phosphate that builds up in gallstones. Carbonate, phosphate, bilirubin. They appear yellow in color if it's pure cholesterol. They vary from gray to dark brown or black. We have enough cholesterol to be radio-opaque. Occurred due to the imbalance of cholesterol and solubilizing agents, excess hepatic cholesterol production, supersaturation of cholesterol, precipitation, gallstones, excess production. And risk factors for forming gallstones: a high cholesterol diet, fat female, fertile 40s, a fat female who's fertile at 40s. This is just an analogy. Sorry, a mnemonic. It's not my own personal words, but high cholesterol content occurs fat female, fertile 40s, fat female, fertile 40s, fat female, fertile 40s, bile salts, phospholipids, terminal, low bile salts or phospholipids. Yeah, because bile salts are normally dissolved, right? So if you have like a terminal ileal resection, you don't reabsorb your bile salts. Yeah, okay. And stasis, starvation, pigment stones, calcium bilirubinate. They can be mixed stones. It can be calcium bilirubinate, calcium phosphate. They're black, radio-opaque. And there's higher levels of bilirubin, such as in hemolysis. So something's up. Usually you form a gallstone when there's an imbalance between cholesterol formation and cholesterol dissolution, which occurs through bile salts and lecithin, and this can happen if there is increased cholesterol production. So female, fat, fertile 40s, or if you have a high cholesterol diet that can overload it. Alternatively, if you have a high concentration of cholesterol due to low other fluids, such as if you are in sepsis, burns, a hypovolemia, ICU diet, and it can cause cholesterol stones, often radiopaque, can be radiopaque yellow due to cholesterol. You also have calcium carbonate, calcium phosphate stones, and your pigment stones are due to calcium phosphate or calcium carbonate. They're darker. They often raise when you have higher bilirubin, such as in hemolysis. Pathological changes in the gallbladder, macroscopic. Oh my god. You're kidding. So many questions. Oh my god. Fibrinous exudate over the serosal surface. What's this? Subserosal hemorrhage, edema of the gallbladder bed. Edema, be a fibrinous exudate, the serosal surface, distended gallbladder macroscopically, be leukocyte infiltration, neutrophils, macrophages, ulceration, necrosis, fibrosis and contraction of the gallbladder, and chronic porcelain gallbladder. Stones are almost always present, and there's hypertrophy and fibrosis. Right, what's going on here? Gallbladder also grossly thickened and fibrosed. Over appearance, solitary calculus. Where is the calculus? The fundus is here. In the fundus, best seen from below. Acute on chronic infection. Fibrosed, you can see that, and there's areas of hemorrhage, and this looks like a cholecystitis. Serosal surface is congested and hemorrhagic and necrotic. There's necrotic regions. Appears to be edematous. To be thickened, and there is impaction. Where at the Hartman's pouch? There's multiple abscesses, fundus, several hemorrhages, the fundus, multiple abscesses at the fundus. Right, so there's abscesses. Abscesses. Fibrosis, pinch multilateral faceted calculi. Whew, that was a hard station. Let's see if I can answer these questions now. How would I enter a full blood count? Hemoglobin is normal. White blood cells is elevated and appears to be a leukocytosis with a neutrophilic predominance. So there is no evidence of hemolysis. Yep, see systemic inflammatory response. Be neutrophil leukocytosis, or ACRP. Presence of gallstones. Yes, it can. What are possible complications? Patients treated with NSAID. What are the most common sites of impaction of gallstones? Why do they form? Neck, cystic duct, Hartman's pouch is the infundibulum of the gallbladder. Infundibulum, cystic duct, or the neck. Neck, infundibulum, cystic duct. And the pathological changes that occur in a gallbladder. It's going to be mucosal inflammation. There could be some subserosal hemorrhage, necrosis. And serosally, there will also be inflammation. There'll be fibrinous exudate in the mucosa. And serosally, you may also notice fibrosis if it's chronic. Enlarged and tense, it's 2 to 3 times the size. There's stones, fibrinous exudate over the serosa, right? And there's a thickened wall. And there's black mucosa from hemorrhage. And there can be some edema, necrosis. Fibrosis, and contraction. Tough case. Let's go back here. Here. Oh, sheesh. Cholecystitis. Oh, am I ready for cholecystitis? Maybe 1 minute. Where is this? I'm ready. Let's go. Let's go. Cholecystitis. A 51-year-old woman presents to the emergency department with an 8-hour history of severe upper abdominal. I'm gonna time this. Let's see if I can smash it in. What else we got? Some upbeat music. Let's go. I'm gonna stand so I can not fall asleep with this. Alright, let's go. A 51-year-old woman presents to the ED with an 8-hour history of severe upper abdominal pain, which radiated around to her back and was associated with nausea and vomiting. On examination, she was distressed from the pain with tachycardia, fever, tenderness in the right upper quadrant. She had episodic epigastric pain, which indicates that there was a prior biliary colic, which one occasion is accompanied by a jaundice. Could be a cholangitis, hepatitis there. Okay, what is my provisional differential diagnosis? Urinalysis is normal. Okay, so my provisional diagnosis is that of acute cholecystitis due to the right upper quadrant pain that radiates to her back, which is characteristic of cholecystitis. There also appears to be nausea and vomiting, which is also consistent with cholecystitis severe pain. My differentials would be other cause of right upper quadrant pain, such as cholelithiasis, biliary colic, and also like to rule out life-threatening causes such as acute coronary syndrome, abdominal aortic aneurysm. Other cause of abdominal pain could include pyelonephritis, pancreatitis, if there is further spread of the cholecystitis. I'd also like to rule out peptic duodenal ulcers, and given that she's, and also potentially cancers, bowel obstruction, for example. What are the anatomical and pathological basis of a current presentation? Well, the severe pain and right upper quadrant pain likely indicates that likely indicates that there is an element of inflammation that has spread to the parietal peritoneum, which has resulted in a sharp right upper quadrant pain. There's radiation to the interscapular region, as there may be concurrent irritation of the phrenic nerve, as there can be irritation of the distended inflamed gallbladder to the diaphragm, and that can be misinterpreted as interscapular pain. Fever could indicate the release of cytokines, potentially subsequent infection as well. That's resulting in a systemic inflammatory response, and past history of epigastric pain indicates potentially biliary colic, which has occurred previously. Pathological basis of a current presentation. Well, anatomically, gallstone normally forms when there is increased amounts of cholesterol and decreased amounts of bile salts and lecithin to dissolve it, and it generally forms in Hartmann's pouch, the infundibulum of the gallbladder, the cystic duct, or the neck of the gallbladder. And what would you ask in history and examination? I would look for any causes, so whether she did have a prior biliary stone, which was passed. I'd ask risk factors, so she's so usually female, 40s, fertile, fat, etc. If she's in her female, she's 40s, she's obese, and I would like to also look at diet, increased dietary cholesterol production, any evidence of any hemolysis disorders, which can increase pigment stones, recent ICU admissions, starvation, hypovolemia, sepsis, which can predispose to it. Rule out my other differentials. And I'd like to also look for complications, to look for any evidence of pancreatitis, generalized sepsis. I'd be asking for fever, and whether this is acute or chronic. Obesity, hyperlipidemia, bowel tract, fever, hypertension, Murphy's sign. Okay, clinical chemistry indicates a biliary pattern of obstruction, as is elevated alk phos and GGT. And what other investigations would I perform? I would also, bedside, I'd like to perform my diagnostic investigation of choice would like to be an ultrasound of the gallbladder, or potentially progress to an MRCP or a, so I would like to bedside order urinalysis to rule out renal causes. I'd like to also do full blood count ESR-CRP looking for signs of infection, ultrasound the gallbladder, get coags profile as patient might be going for surgery. Might like to also do an ECG bedside, and laboratory like to also potentially order a chest x-ray to rule out pneumonia if that is one of my differentials. If I'm worried about a AAA, might also like to do a CT of the abdomen and a MRCP if my findings are equivocal. How would I interpret this full blood count? There is high levels of neutrophils. What did I do? Trust me to step up my entire lighting. Come on, man. Work. There we go. No more touching. Alright. So, indicates that there is leukocytosis and neutrophilic predominance, which indicates that there is likely fever, likely a systemic inflammatory response, and toxic granulation of neutrophil supports. This is no hemolysis, which could be consistent with a cholesterol stone or pigment stone. There's gallstones. What this clinical end can occur? Yes, acalculous gallstones may occur, and they may occur due to increased concentration of cholesterol, which can result in a more viscous biliary sludge that's prone to precipitating, and it can also occur due to decreased diet and release of decreased feeding and decreased release of cholecystokinin, which increases stasis as there is no gallbladder contraction. These two features can result in viscous secretions and potentially precipitate and form obstruction in that sense, although there is no macroscopic stone present. What are the possible complications in this case? Okay, there could be obstruction, which can cause gallbladder mucosal hydrops. It can be extension to the ampulla vata, causing pancreatitis. There may also be a rupture, which can result in necrosis, hemorrhage, peritonitis, sepsis, and death. Stasis, mucosal ischemia, we said that, fistula formation, gallstone ileus, and it can be cancer. In the long term, you can get gallbladder cancer, gallstones, and cystic duct, compression of the common bile duct, obstruction, jaundice, intrinsic compression, surgical removal of Nephrotic Syndrome, gallstone impacts the neck of the gallbladder, causes compression of the common bile duct, obstruction, and jaundice. Cystic duct causes compression of the common bile duct. Common bile duct. And jaundice. Can be a porcine gall, fibrosis, long-term chronic cancer. So to sum things up again, we could get obstructive symptoms. You can get hydrops, mucosal formation, you get pancreatitis, you can get an abscess, empyema, you can get, not empyema, you can get an abscess, you can get fistula formation, you can get extension, rupture, you can get chronic cholecystitis, fibrosis, and you can get gallbladder cancer. Patients treated with antibiotics, I like to put them on ceftriaxone if there's no suspected infection. If there is suspected infection, we would like to put them on broad anaerobe, as E. coli, Enterococcus, Proteus can cause disease in this case. And so I'm concerned about, I'd like to put them on ciprofloxacin and analgesia NSAIDs, as they're less likely to cause irritation and contraction of the sphincter of Oddi. What are the common types of stones? Well, there is your cholesterol stones, which occur due to cholesterol, calcium carbonate, calcium phosphate, and bilirubin, and they can be radiopaque, yellow in color. They can also be your pigment stones, which are formed from calcium carbonate, calcium phosphate, and they're often darker in appearance. And what are the common sites for impaction? There's the neck, the cystic duct, and Hartmann's pouch, which is the infundibulum, the gallbladder. Pathological changes in the gallbladder, well, there'll be serosal inflammation, and there'll be deposition of proteins. There'll be exudate, fibrinous exudate over the serosal surface. There will be areas of abscess formation in the mucosal surface. There can also be damage to the cellular layer microscopically. It's a shit answer, I need to revise that. So pathological changes can be broken down to macroscopic, microscopic, and the macroscopic changes in the acute setting could include serosal inflammation with fibrinous exudate. There may also be areas of hemorrhage subserosally. Microscopically, we may observe necrosis of regions of the gallbladder. There will be generalized edema over the layers. And what else would there be? Micro thickened edema, maybe enlarged gallbladder. It's enlarged. There'll be serosal inflammation. It's enlarged. Areas of hemorrhage. There'll be necrosis, vascular congestion, and there'll be fibrosis, necrosis, vascular congestion, edema. Oh, my Jesus Christ. Alright. Got a lot of this crap, so I need to do. You know what? I think we've done 3 hours today. I might quickly revise this one case one last time, and then I'm probably done for today. So let's go into it. Alright, one more time. Let's go. One more time. So, alright, acute cholecystitis. 51-year-old woman presents with severe upper abdominal pain, right upper quadrant, nausea, vomiting, tachycardic, episodic, previously jaundice, tachycardic, hypertensive, and urinalysis is normal. What's my provisional diagnosis? I need to start a timer so I actually sound like an exam answer. And we'll get some good pump-up music going. Get this one. Not really pump up, but you know, it be what it be. My provisional diagnosis is that of is acute cholecystitis, given the potential previous history indicative of biliary colic, given episodic epigastric pain and jaundice, presence of right upper quadrant pain with interscapular or back radiation, which is characteristic of cholecystitis. My differentials would be, I'd like to exclude life-threatening causes of abdominal pain. Could be acute coronary syndrome, inferior myocardial infarct. I'd like to also rule out lower lobe pneumonias. Triple A, and then other gastrointestinal causes of abdominal pain could be pancreatitis, especially if we have extension of the cholecystitis, and like to rule out duodenal or peptic ulcers, gastroenteritis, small bowel obstruction, pyelonephritis, and diverticular disease potentially. My anatomical and pathological basis of a current presentation. Well, pathologically, a gallstone forms when there is an excess of cholesterol relative to its solubilizing agents such as lecithin or bile salts. As a result, there will be the formation of gallstones, which may form at the neck, the cystic duct, or Hartmann's pouch obstructing the gallbladder. This is going to increase intraluminal pressure, cause stasis, and cause lecithin to convert into toxic lysolecithin and expose bile salts to the epithelium of the gallbladder, causing inflammation, edema, and potentially rupture, which can cause generalized peritonitis. The right upper quadrant pain would be due to peritoneal inflammation, and fever may be due to a systemic inflammatory response that is generated with a cytokine release in response to gallbladder inflammation. There may be also superimposed infection. What would I ask on history and examination? In the history, I would be looking for risk factors that puts a patient at higher risk of a gallstone. So given her age, her gender, she's already at higher risk. And I'm also like to get BMI. Obesity can increase the risk. And high cholesterol diet may also increase risk. Other factors may also be whether she's had prior cholecystitis. I like to rule out if this is acute or an acute on chronic picture. If there is any family history of any biliary cancers, which could also indicate coli. Other causes of jaundice in my differentials. Examination, I'd like to look for Murphy's sign. So seeing on the right upper quadrant can elicit Murphy's sign, yeah. Need to revise Murphy's sign, but yeah. Might see jaundice, I might see guarding rigidity of the right upper quadrant. Investigations I would perform. So my diagnostic investigation of choice would be a ultrasound of the abdomen. I may also like to progress to MRCP, magnetic resonance cholangiopancreatography. Bedside investigations could be an ECG to rule out an MI. I like to also do urinalysis to rule out any renal, pyelonephritis, for example. Then ESR-CRP full blood count to look for any evidence of infection, even hemolysis, which can predispose to pigment stones, and EUCs, LFTs for baseline, and to look for any evidence of hepatitis, which can also cause jaundice. And I'd like to, and also characterize a biliary pattern of obstruction. I'd like to do coags as well, as a patient might be going for cholecystectomy, and might like to progress into imaging, doing a chest x-ray to rule out pneumonia, and then a ultrasound, MRCP, maybe CT abdomen if equivocal results. Clinical chemistry, well, the hemoglobin appears to be normal. This appears to be a neutrophilic leukocytosis, and the presence of toxic granulation on neutrophils indicates that there is a systemic inflammatory response syndrome, which is also consistent with a raised CRP of 660. How would I interpret? Yes, upper abdominal ultrasound. Can a clinical presentation occur in the absence of abnormalities? Yes. So, increased fasting, such as post-ICU admission, and decreased dietary intake can decrease cholecystokinin, which results in decreased contraction of the gallbladder, stasis, which can predispose to the formation of increased viscous gallbladder secretions, and they can also be low volume and volume depletion states such as sepsis, hypovolemia, burns, which can increase the concentration of bile salts and cholesterol, predisposing to a more viscous gallbladder secretions, which can cause obstruction in themselves, and that can cause similar symptoms. What are the possible complications? Well, the complications of cholecystitis include extension. There can be extension to the pancreas causing pancreatitis. There may also be increased fluid buildup in the gallbladder, causing mucocele or hydrops. There may also be inflammation following rupture. There may be generalized peritonitis, can be sepsis, which can also lead to septic shock, which can be fatal. There can also concurrent infection of the gallbladder, necrosis, chronic cholecystitis, and there can also be gallbladder cancer. What are the most common sites of impaction? The neck, the fundus, the neck, Hartman's pouch, infundibulum. So infundibulum, cystic duct, neck. Pathological changes, it would be enlarged, first of all, 2 to 3 times the size of a normal gallbladder. There will be fibrinous exudate over the serosa. It might be edema, and microscopically you may notice necrosis, vascular congestion, and then will also be fibrosis if it's a chronic cholecystitis. Alright everyone, I think we have done enough time. Have we? Yo, 2 people still going. That is a grind. Good job. Good job. I'll probably head off for today because I need to do a bit of catch up on sleep and also stay consistent. You don't want to die out or burn out early from revision. So good job. And feel free to comment down below if you made it to the end. Maybe an emoji so I know that you beat me today. But yeah, maybe what I'll do, where's my, right back. Saban, you beat me, and Rahul, good job. Let me just pause. It's 3 a.m. where I am, so it makes sense. But good job, you all still beat me regardless, which is good. I'm just going to... Alright, I will catch you all tomorrow. We'll try getting another session. Thank you for joining and catch you tomorrow.